person was just sitting in an MRI or lying in an MRI machine, and when they were thinking about what happened, the areas of the brain lit up, which would be as if that event was happening again, but the thalamus, the place where the sensory inputs comes in, was silent. There was no color there. So basically, as far as the brain is concerned, even on a neurobiological level, that was real. Hello and welcome to the Nirvana Principle Show. You're tuned in to myself, Dr. Hassan Mallick. I'm a psychiatric registrar. I work in London. And thank you to Melodic Distraction Radio to give me an hour every month to talk to you about concepts in psychology and psychiatry and how mental health affects our lives and the world we live in. We're going to be talking about trauma today. It's a difficult topic. And if you feel that this is not right for you to listen right now, please feel free to check out our other episodes, or whatever floats your boat. Even during the show, if you feel something is getting a bit heavy, take a step back, and you can always come back to this later, or like I said, find other ways to spend your time. So I've started work these days in a community mental health team. And while I was sitting at my desk, I noticed that there was this one lady, and she was like a street therapist. She'd just meet a stranger or colleague, and she'd be like, hey, she just do like some small, like 2 minutes of therapy. Like, if someone's just moaning and saying, oh man, I can't do this. And she hears it. She's like, why are you saying that? You can do it. Look at you, you're like a doctor, or you're a professional. And it's just somehow fixes that small cognitive distortion somewhere. Or if she'll see someone who looks a bit anxious, no relation, no patient of hers, she'll be like, let's do like a grounding exercise together. So I was like, okay, I think this person obviously enjoys helping other people through their problems. And when I talked to her, turns out she is a therapist, as I suspected. And her name is Josie Geddes. Am I pronouncing it correctly, or Geddes? Yeah. Geddes. Okay, so Josie, just hello to you, and if you want to say hello to our listeners today.
Hi, thank you very much for inviting me, and hello to everybody. I hope today's discussion will be of use.
Okay, I just wanted to know a little bit about you. I mean, I told you how I see you in the office, but how would someone else see you? How would your patients see you? What is your role? How do you spend your time? How are you related to mental health?
So I've been working in the community mental health team for a year. I actually joined a year ago, and my current role is a complex emotional needs clinician. And complex emotional needs is the new term for kind of personality disorder. And I think it's slightly less offensive than saying that your personality is disordered. So we're recognizing more broadly it's complex emotional needs. So the role involves assessing and offering, where appropriate, treatment to patients with a diagnosis of emotionally unstable personality disorder, also known as borderline personality disorder, or people that would identify. So they don't necessarily have to have the diagnosis, but we recognize that could describe their difficulty, and they identify with that.
Yeah, I mean, you've been in the business for a bit. I feel like we were talking off air, and you've kind of found that healing trauma or helping those who've we call it different things, and we'll discuss in our show what we exactly mean by that. But what was your journey like? Were you always like, all right, I'm gonna be a therapist, that's me, baby?
No, absolutely not. I initially wanted to be a lawyer. I think me and my mum, there were programs that we'd watched together, and that was also what my mum wanted me to be. And I think when you're small, you don't have a concept of there being much other than lawyers or doctors in the world.
Engineers as well.
Yeah.
Okay, the big three, so to say. Yeah.
Right.
Yeah.
And then actually, as I kind of progressed, I didn't do particularly well when I went to secondary school, and that I'd like to say that it was more about the school than me.
Of course.
The story I told myself.
Yes.
Then things became increasingly difficult in my teenage years, and I didn't manage to complete A levels. I was kicked out of my college. So the initial plan of these kind of really high-end careers, that didn't work out for me. And I ended up thinking, actually, I think I want to be a probation officer, probably in response to my dad spending quite a lot of time in prison. And they said, actually, you're not ready to be a probation officer. You don't actually have much life experience. You're quite young. Go and do a bit of volunteering, work with people with complex difficulties that might come into the prison system, and apply again next year. And I ended up volunteering in a local drug and alcohol service and stayed there for 15 years. That was
That's a long volunteer stint. Did you get a certificate? You get a certificate at the end, at least?
Well, I actually then became an employee. So I did a year of volunteering, and then worked on a crack cocaine day program, and then eventually on a non-abstinent based treatment program, a day program for people in South London.
What do you mean? Sorry, what do you mean by non-abstinent?
So non-abstinent means people that are still in active addiction, so still using substances as a way to cope, and kind of pre going into detox and rehab. So kind of having to engage in a program to see how they tolerate it, and then often being referred on to detox programs and then residential rehabs, which were abstinent based.
Yeah, so I think the acceptance of people's life choices was something you were doing early on in your career.
Yeah, very much. And working with people who use crack and heroin and alcohol problematically, it's complex trauma. It's people that have had incredibly difficult lives, and unfortunately, due to their life choices, add to the trauma on a regular basis. Life continues to be incredibly difficult. Yeah, it was hard to see.
Yeah. So you, from there, from substance misuse, you now have pretty much all the letters of the alphabet that therapists can have. You do MBT therapy, EMDR, CBT, you're a complex emotional needs clinician, like an all-rounded therapist. And we'll talk a little bit in the last segment of our show about what exactly those terms mean, what they are. So what was your journey from there, from deciding to now get like an official, what do you have to do? Sorry, do you have to study for it? Do you have to work for it?
So I kind of felt like the interventions I was able to offer were quite limited, and felt that, within the remit of a drug and alcohol service, I wasn't quite doing what I wanted, which was helping people to make effective and lifelong changes. And then wanted to study. So I did counseling first of all. I went and did some counseling courses, and then ended up doing a degree in psychodynamic short-term psychodynamic counseling and CBT. It's not a course that runs anymore. I think they recognized the error in their ways quite soon. Like,
were you the one where they decided this? Were you the one where they were like, okay, this is not going to work. We need to like separate psychodynamic from
I think they
cognitive.
ran it twice after ours and was like, how can you ask someone to hold these two concepts?
Yeah.
2 placements, 2 supervisions, 2 studies.
Wow.
It was
Okay.
Because psychodynamic was my thing, actually. That was the thing that made sense to me.
So psychodynamic is like the long-term one, the one where it's more about the subtext or the subconscious aspects, while CBT is more like behavior therapy, where like, okay, you're doing X and we need to change that, but you're doing X because of Y, or you...
So I think somebody has explained it quite nicely to me, and captured it nicely. In psychodynamic, we want to understand how the fire started. In CBT, we want to put the fire out.
Oh, that's very cool. Without the fireman costumes, unfortunately. I shouldn't say costume, should call it uniform. It's not a costume. Okay. So then which one did you choose first? You went for CBT?
Yeah, I mean, interestingly, like I said, that the passion for me was psychodynamic. It made sense to me that we're looking at these kind of relationship patterns. We're looking at the relationship we had with our early caregivers and the significant impact that that has on how we begin to understand ourselves and relate to other people. That's still something that I operate from. But actually, once I had completed my degree, psychodynamic was not where the work was, nor was it where the money was. CBT was the way to go. David Clark, who is the kind of founder of IAPT, which is increasing access to psychological therapies, and it was a nationwide program that's been rolled out and continues to be available to everybody in this country. And they were kind of bankrolling CBT therapists. And so I was able to do a postgrad in high intensity CBT and didn't have to pay anything for it, and was paid to study for a year.
Woo, that's the dream. It's like a college student with cash on their hands. Yeah.
Why would you say no?
Yeah, that sounds like a sweet deal. All right, so you did all of these things, and now what we're just going to talk about today is going to be a bit more about specifically around the concepts of trauma, the phases of trauma as well. I like to call it, terminologies like post-traumatic stress disorder or PTSD, as well as complex trauma. So I'm looking forward to learn a bit today. And I feel we also wanted to talk a little bit about treatment and also about having conversations about trauma as well. Both, even for, let's say, for myself, even being a mental health professional, it's sometimes difficult to understand how to talk about it and how to understand people's narratives in a, I would say, respectful way, or in a dignified way, maybe. So I'm hoping we could touch on those themes as well.
Yeah, absolutely.
We'll be back and we'll talk about trauma with Josie Geddes.
Hi, this is Josie Geddes. You're listening to Nirvana Principle Show. I'm here with Dr. Hassan Mallick, and today we're having a conversation about trauma.
What I know about trauma, at least definition-wise, is that it's it's adversity in a could be for a physical or a mental way, which happens. My concept has always been that it's something that happens in childhood. Can you tell me what your understanding is of trauma?
I kind of capture trauma as something that should never happen, something that has happened to somebody that should never have happened. And it can be at the hands of another human being. It often is. And our struggle to make sense of what happened. So we can see with complex trauma that this will have been an accumulation of more than one incident of trauma through our formative years, through our childhood, having a significant impact on what we're learning about ourselves, what we're learning about other people, and what we learn about being in this world. And then we can also have incidents that happen later on in life. We might have had a fairly okay experience growing up, and then the bad thing happens when we're a bit older. And it's just experienced as incredibly destabilizing, and it feels impossible to be able to think about anything other than the awful thing or things that have happened that change the person from that moment forward.
And is the person self-aware that this is, I mean, we don't have to label it trauma, but are they aware that this is an incident which happened, which has changed my life or which affects me to this very day?
It's an interesting question, and I guess it's relative. It can also be really difficult when somebody might not have had their experience validated, that actually maybe I had some role within that. Maybe there was something that I had done that had invited or initiated that thing to have happened. If I hadn't done that thing, said that thing, worn that thing, behaved in that way, gone to that place, interacted with that person, none of that would have happened. So I imagine that people have an understanding that there's life before the incident and there's life after the incident. Although if the incidents were occurring when we were very young, we have little concept of life before the incident. Life has always been incredibly difficult.
Okay, I mean, just for someone listening, if you've just tuned in, we will be talking about some difficult things. I think we will be talking about trauma, whether that's sexual, whether that's an accident you've been in, or something you've seen. We might reference it. So again, if this is something which is difficult for you to hear, then we would suggest maybe catching another show for now. So for right now, we want to understand a little bit about the effects. Is it solely mental or cognitive, or is it something which is there throughout the body? Does it have any physical manifestation, or is it just solely, what should I say, psychological, maybe, for lack of a better word?
No, what we see is that it has an impact on the whole being, the whole person. So if we imagine that at the point of the incident, the normal processing function of the brain has been interrupted because this awful thing is happening. And because we can't physically escape from that, our brain escapes by shutting off its normal functions that would take in the information and process the information of what's happening. And so that process stops, and we're left with the memory fragmented. And there's a great book called The Body Keeps the Score, which kind of talks a little bit more about the impact that this has on the body, that actually the body holds on to the trauma memory, and it can manifest in very many different ways. We have ideas that things like fibromyalgia are actually trauma. It's the body chronic pain, kind of maybe things that people experience within their body that can't be medically explained. It's probably trauma. Your body is really holding on to the shock of the thing or things that have happened to you. People feeling in their threat system all the time, hyper vigilant, for not being safe, and the impact that has on your mind, your energy, your ability to engage day to day, focus, learn, interact. It affects every single part of a person's being.
Yeah, I was reading recently. They've started doing some more, by they I mean research. I always refer to them as they, but scientists have started doing a bit more research on the actual imaging, and like Josie was saying with memory. So we do know that specific. So most of our memory, there are two main regions, I would say, which are, one is called the hippocampus, and where memories are stored, but it is closely linked to an area which deals with emotion. Broadly, we call that the limbic system. Am I correct in saying that?
Yes.
So the emotions you feel or associated with the memory, kind of, I would say they complement each other, or they're part of the same circuit, as we like to say. And that also leads to a response. For example, if you're, I think the classic example is you're walking down a dark road and suddenly a rabid dog starts barking at you, which actually has happened to me. So I'm not sure, but my immediate reaction was to scream. I like to think of it as a very macho scream, but I don't think it was. But it wasn't. I didn't even think. I just yelled as soon as I saw a thread, this snarling thing coming out of the shadows at me. I didn't know what it was. I didn't know it was a dog. But imagination ran wild, and for a second, I had a second to assess the situation. So I was like, okay, do I run? Do I fight it? Or do I stay where I am? Most of my friends with dogs, they had told me that, okay, buddy, if it's coming for you, don't run. The dog will chase you. So I froze. So I stayed there, and the doggy apparently was probably more scared of me than I was of it. But yes, but that immediately the body was ready for something cataclysmic to happen. There's more blood flow to muscles. There's everything that's not needed to fight or flight slows down. Some of it is hormonal as well. For the biology students out there, it's like the HPA axis. We call it the hypothalamic, pituitary, and adrenal. So adrenals, the glands on top of your kidneys, is where adrenaline comes from. So I'm kind of or we are talking about trauma as something negative, but there's also the response to it isn't always dysfunctional. if you're playing sports, for example, and there's a clutch shot you have to make, that burst of adrenaline gives you that energy, gives you what you need in that moment to survive.
Mm.
So how does this become dysfunctional then, Josie?
So you mentioned some good points, which is about that kind of fight, flight, or freeze response. In fact, I think there's 7 stages, there's 7 Fs of that, leading up to faint. And that decision is made within less than a second. You've kind of assessed the situation. And often what we see with people experiencing complex trauma or PTSD is lots of shame and regret about the decision that they made, that I should have done something differently. And that compounds the incident. Gosh, not only did the thing happen, the way that I responded, that wasn't acceptable. Should have done better than that. I should have been able to be more effective. I should have fought the dog, or I should have, I should have responded in a different way. That's important. And so what that then does is it develops a new belief about the person. I suddenly have learnt about myself that I am weak, I am vulnerable, I am disgusting, whatever other very painful cognition I then begin to believe about myself. So my world and my self-image changes because of these things that have happened to me. And then we think about the way that people around us respond. Often what we have learned is it's not just about the incident. In fact, it's much more compounded by the way that the people around us respond. The bad thing happens, so if we think about the anxiety equation, which is increased threat, limited ability to cope, and less of a limited belief that I'm going to be rescued by someone, that equals anxiety. That's the equation. All bets are off. It's a bad situation. But if the bad thing happens and I didn't cope, but actually the people around me really rally around lots of support and love and care and encouragement and kindness, well, that makes a big difference. So the bad thing happens, I didn't cope, nobody responded, or actually people responded and made it worse. Mm-hmm. Well, we're seeing the recipe for trauma and PTSD.
We're going to talk a little bit more about kind of using a couple of specific disorders as examples in our next segment on how exactly that the phases of it. But we have a few minutes in this segment. I wanted to ask that how do we, well, 2 things. One was, the initial question is that how do we talk to someone about their trauma, or if someone is telling us their trauma, how do we respond? And I guess a second, I don't know if it's an appropriate question, but it's just more like, do you have to talk about trauma? Do you have to share your experiences?
One of the things that I do want to kind of mention, another really key part of what develops PTSD is, so like you were talking about this, the kind of hippocampus, and there's something called adaptive information processing. And when that process is happening, I'm absorbing the information in a situation and I'm processing the information in a helpful and adaptive way. When I'm in a really threatening situation and my brain is not functioning and the right side and the left side are not communicating together, then that process has been interrupted. And what we do in trauma treatment is encourage the left and the right side of the brain to start to communicate again, because each part holds very important information that the other part needs. So one part is kind of the facts, the details of it. The other is a little bit more kind of language and image, and we need, and smells and sounds, and those 2 things need to communicate. So, some of the ideas that we have are the fact that you're getting the flashbacks and the intrusive images is your brain's attempt to try and work through the story. And obviously, because what we're thinking about is absolutely horrific, we push it away all the time. We're constantly avoiding the feeling. It's intense. Who wants to feel like that? Other people don't tolerate listening to the story because it's horrific. Who wants to hear the details of rape or abuse or a knife attack or a horrific car crash, somebody dying? Nobody wants to hear the fine details of that. But actually, we know that the brain needs to go through the fine details in order to piece all of the fractured information back together in a coherent way, that it then becomes a narrative that can get put into the hippocampus. It can get stored as a cohesive memory. So how do we talk to people about trauma? I think we allow people to talk in a way that feels comfortable for them, and just validation and support and care and kindness. And I think what's important to understand is that PTSD, particularly, it doesn't go unless it's treated. It can't move out of the amygdala, which is where it's been stored in the threat system, it doesn't move with medication. It doesn't tend to move with just kind of a conversation. There's particular conversations that need to be had in order for that to happen. So encouraging people to engage in local services or private therapy to have a trauma intervention. That's the stuff that helps.
Okay, so I think you've answered most of my question, and thank you for that. I feel it was very well explained. So I feel when we're talking about therapy, in our last part of our show, we'll talk a little bit about how to listen to someone. Okay, so I feel like we're getting deeper and deeper and into more heavier topics. Maybe it'd be nice to take a short break. Welcome back to the Nirvana Principle Show. Today we're talking about a difficult topic. We're talking about trauma. So this is just a heads up for you that some of the things that we discuss may be difficult, and much like you listening, I myself am also learning about how to have a conversation regarding trauma and try to understand it better. And if you have experienced this, or you do feel that myself or during our conversation we may make light of events or things like that, doesn't necessarily mean how we feel about it. Our conversation is more trying to understand better and help you hopefully understand a bit better about what goes on in the body, the mind, and in our relationships once we have adverse experiences. One word which comes up often is complex trauma. And when you think about trauma, one of the acronyms you might think about is PTSD. So I'm hoping, Josie, we can talk about those two and what your understanding is about them.
Yes, absolutely. So there is a difference between trauma, complex trauma, and complex PTSD. And the difference is that with PTSD, what we would need to see is reliving or re-experiencing. So that's where somebody is having kind of intrusive images of the experience. And the difference is that it feels as if the thing is happening again. So there will be some people that might have intrusive images about a memory, but have an understanding that it's not happening again. I know that I am here now and it's 10 years later and I'm in a different room. Feels difficult, but I know it's not happening again. With PTSD, there isn't that ability. The whole system has been activated, and it's as if the incident is reoccurring, and that's what determines that it's actually PTSD. So that's a slight differentiation.
Yeah, I mean, for PTSD, one of the same book that you mentioned earlier, The Body Keeps Score, gave an example of a couple, a husband and a wife who had a horrific car accident, one of the worst ones in Canada. And they, apart from, thankfully, they were unhurt, but they did see a lot of death and destruction. And their response to it was different. One of the people, they kind of relived what you were talking about, kind of just got flashbacks back to the incident, the car turning over, and they actually did the brain scan, and they saw that there's no, like, for example, if you have a sensory experience, if I touch something or if I smell something, it comes into the brain through the thalamus, and it kind of tells that sense is made sense of, if that's not too many senses. But that person was just sitting in an MRI or lying in an MRI machine, and when they were thinking about what happened, the areas of the brain lit up, which would be as if that event was happening again, but the thalamus, the place where the sensory inputs comes in, was silent. There was no color there. So basically, as far as the brain is concerned, even on a neurobiological level, that was real and was happening again.
And then the other part of the brain that isn't working is I can't remember the term, but it's the part that's responsible for speech. So in fact, I'm not even able to communicate, like you're saying, make sense of or put to language, give words to the experience. And again, that's about the right and the left not communicating together. But also makes me think I have a teenage son who has a VR headset.
Yeah.
And one of the games on that is you have to walk the plank.
Yeah.
So I
Okay,
know
of
I'm
course.
in my living room,
Yeah.
and you're at the top of a New York story skyscraper,
Yeah.
and you have to walk the plank. And every part of my brain and body feels like I'm actually walking the plank, similar to a flashback. You don't, it's it feels like it's real. If you imagine it, it's as good as it happening as far as the brain and body are concerned.
They're actually using VR for exposure therapy now these days for things like agoraphobia or certain types of things that, okay, you can take the VR set off, but it's a nice way. I don't know if nice is the correct word, but it's a way to expose someone to that again.
Develop some neural pathways and approach some avoidance. Absolutely. Yeah.
Tell me about, you mentioned PTSD. Tell me about complex trauma.
So complex trauma is where there has been more than one incident. Complex is that there's kind of numerous incidents of that. And there can be themes. So we can identify that a theme of violence or a theme of neglect, different themes of abuse. And we can see that happening kind of throughout a person's life. It might be within different times of their life with a particular person over multiple incidents, within numerous relationships, kind of started in childhood and then seem to keep finding partners that elicit the same things within those relationships. And that's what makes it complex, but it doesn't mean we can't treat it.
You mentioned relationships. I think a common one, or one which I guess I kind of as an adult resonated with, is that you kind of feel more comfortable in dysfunctional relationships sometimes because of the trauma you had, because it's familiar.
Yeah, absolutely. I mean, it's called the compulsion to repeat. So, one of my supervisors said, we copy and paste. That's what's happened. And so that's what I do. That's what I'm used to. We see that in many different ways that might transpire, even, in terms of maybe as a child, you might have been hit and maybe thought, gosh, I would never hit my own child. And then unfortunately, when you become a parent yourself, you realize that you're kind of doing that same behavior. And similarly, within that trauma, we may seek out similar relationships to mirror the experiences we had in our formative years. It's just what we know. It's what we feel somewhat familiar with, and we gravitate to what is familiar.
Is that what we call generational trauma? I've heard like that term thrown around a bit. Is that what it is? We just described that the compulsion to repeat is there across generations.
We can definitely see that for sure. I kind of will think with patients about the lines of trauma that run through generations and generations. It didn't start with you. Even if there has been an incident where something has happened to you outside of the family, but we then think about, gosh, how was the family able to respond and support you? Wasn't great. Okay, let's think about that. Because we're also thinking about what resources exist within a family. For people that have experienced complex trauma, there is a paucity of resources within the family to draw upon to navigate these challenges, which unfortunately makes the challenge even more difficult because you haven't got the tribe that you need to help you with that.
So I mentioned that there were two people in the example I gave, in the example of the car accident. When they scanned the wife and she was thinking about, or she was asked to think about that car accident again, her brain scan was like empty. It was like super, like it shows up as white. There's no color there. And it turns out that basically her brain was shutting down, and it was what we call dissociating. Can you tell me about your experiences with that, Josie?
So dissociation is it's a survival strategy. It protects us. So when we physically can't leave a situation, the brain will kind of escape as a way of protecting us. You know, this is too awful, too horrific to be present for and absorb, and so we kind of shut off. And dissociation is something that every single one of us do. If you think about it on a bit of a continuum, you know, kind of a daydream is dissociating. Being on a journey and arriving somewhere and realizing, because I haven't really taken much notice of how I got here, that's dissociation. So we all do it to a greater or lesser extent. But what we see with people who have had significant trauma in their lives is there may be significant dissociation. So any kind of trigger which stimulates quite a strong feeling, the person may have learned to dissociate. So you may notice that it can be difficult to engage them, or you may notice that they don't seem to be very present. And again, that's their brain is trying to look after them by protecting them from feeling very difficult feelings. So it makes sense. It's functional. But what we hope to do through treatment is develop the person's capacity to tolerate feelings for longer, and to move what we'd call a switch point. So from the person's ability to tolerate to not tolerating, that we would try to lengthen that. And again, with treating the trauma.
I'm just wondering whether do you want to catch anything else in this phases of trauma, or do you want to maybe head on to our talk about healing these wounds?
Yeah, let's have a think about healing.
All right, so we'll be back right after this. How do you create a safe space? What is the conversation you initially have with them? That, hello, my name is Hassan. Hi, Josie. I need some help. How does this work?
So I'm always interested in the historical experience of therapy. I think there's a lot of information that is held there. Somebody's capacity to engage in therapy, how they experience that intervention, were they able to complete it? Were there any lasting effects of that intervention? Is there a pattern of things not working, not getting on with a therapist, or not finding it useful, or finding it making things worse? Because that's all information for us, you know, as to, is therapy indicated, and is now the right time? I guess there's a sense that, gosh, if somebody's coming for therapy, then yes, let's do it now. That's not always the case. It might be that actually what we think the most useful thing for you would be right now is to really develop the scaffolding around you to increase your day-to-day functioning, because trauma work is very hard. I am going to ask you to think about and feel, more importantly, the stuff that you have been fighting not to feel. And we have to move you through some very painful and distressing memories in order for things to get better. So if life is already incredibly difficult, I don't want to add to that. I want to make sure that things are as good as they could be before making things worse for you. So initially that might be what we would call social prescribing. So just thinking about kind of local services that you might be able to engage in, increasing day-to-day activity, developing relationship with somebody, a friend, a partner, a parent, just so that you've got a bit more scaffolding, that you're a little bit more held. For some people that's not possible, and we can also do that within the treatment, which is a phase of stabilization, and it's about developing people's capacity to regulate themselves when things get very, very intense. So we might, particularly in EMDR, we might develop a safe place, and that's just a place that you can imagine where you feel safe or calm. Safe might feel a trigger word. So just that it's somewhere that the body feels somewhat regulated. The mind is quieter, it's peaceful, it's pleasant. And people can be as creative as they want with that. It might be an actual memory of somewhere they've actually been. Oh, I loved it there and I felt great, brilliant, let's go there. Or it could be, I'm not sure that I've ever felt safe or calm or peaceful anywhere. Can you imagine what that place would be like? You know, you can invent anything, imagine anything. And it's interesting. And do you want people to be there with you? Would you like to be alone? What can you hear? You want to make it as visceral as possible. What can you smell? What images are in your mind as you're here? And the key thing is, what does it feel like in the body? Because we're interested in the body having a different experience, because it's in fact the body and the emotion that we're treating. It's less the images, it's what those images do to the body. So we want you to feel differently when you're in that place. And then and that might be as much as we do grounding techniques, external focus of attention. So people have become preoccupied with paying attention to the thoughts in their minds and the sensations in their body, and just training people in a kind of mindfulness approach to notice what else exists in their world, what they can hear and see and feel and smell. And that can last for weeks, months for some people. And for some people, that is as much as we might do, because moving into the trauma memory may not be indicated. And if we decide to move into the trauma memory, then we can be thinking about EMDR.
You mentioned EMDR before. What does it stand for?
So it stands for eye movement desensitization reprocessing, and it's a treatment that was developed by a lady called Francine Shapiro. And actually, she is a psychologist in America, and she had noticed that she was having a difficulty with something that happened in her life. And she reports that she was walking through the park and her eyes were kind of moving between objects in the park. And she noticed, gosh, that seemed to kind of make her feel a little bit better. And that was the beginnings of her developing this treatment. What she has said, and she died, unfortunately, I think last year, she has said, if I had my time again, I would not call it EMDR. She'd just call it reprocessing.
Yeah.
Because we don't just use eye movement now. It's what we call bilateral stimulation. So as long as we're activating the left and the right hemisphere of the brain, which initially we did through eye movement, but we can also now do through, so they can do what's called a butterfly hug, where the patient just taps themselves, or I might tap their legs, or we use a bar, or sometimes people can use headphones and they'll have a sound that activates in each side. So there's many different ways we can do it.
So the idea is to kind of join the right and left brain together, and the memories which you mentioned were fragmented, kind of like creating new connections between them.
So it's definitely one of my favorite interventions, and it's an incredible thing to observe as somebody who is able to tolerate EMDR does it. You activate the trauma memory. So the thing about EMDR is they don't have to give you too much detail about the trauma memory. I just need to know what the worst moment was and what you believed about yourself in that moment and how you felt. And you activate that trauma memory. So you need the patient to be able to feel it. You say, okay, can you feel that? Yes. Okay, go with that. And then you just allow the brain to go wherever it wants. So they say it's like kind of free association on kind of crack. It's
oh man, I love free association. I used to do it with my friends a lot, but then things started getting weird, and they're like and then started getting awkward. I was like, okay man, you are filthy, Hassan. I'm like, I'm sorry, it's not me, it's my head.
Safe space, no judgment.
Yeah. Okay, so that sounds cool. That's kind of like using the conscious movement or the conscious brain to get into, I want to call it subconscious. Is that an appropriate way to think about it?
So it is, and I guess, and it's allowing the brain to do what it wants to do anyway. So some of the ideas, that as the brain is going into a flashback, it's about trying to connect with the memory and piece things together. And so actually what we're doing by activating the left and the right, so by the bilateral stimulation, we're also attempting to keep the patient in the room with us as well, and not going into dissociation fully into the trauma memory, because we don't want that. So it's about keeping them in an optimal window of tolerance, not completely activated, but enough to feel it and allow the brain to make the links and move into adaptive information processing that it hadn't been able to before. And it's a wonderful thing. And you can kind of notice people going all over the place, but it all makes sense. And at the end, so you do kind of sets of about 20 to 30, and then you're just checking in every night. Okay, where are you now? What can you see? Okay, go with that. And then at the end, then saying, gosh, I realized that that was linked to that, and or I'd forgotten that part. Gosh, I didn't remember that. And in the processing, it comes, and you're just filling in the pieces, and developing a clearer narrative, and hopefully helping to move away from the I am weak, which of course they're not, to I'm safe, I'm strong, I'm brave.
So I myself am kind of like, I'm very optimistic and hold EMDR with high regard, simply because, like I said, it kind of blurs the brain versus the mind kind of debate. So, but what about when you consciously or cognitively decide, I think trauma-focused cognitive behavioral therapy, TFCBT is how the cool kids call it. What's different in that?
So trauma-focused CBT is generally something that you would use to treat a single incident. So a car crash, an attack, where there's less kind of complexity. And with trauma-focused, what you're doing is somebody is talking through in great detail the incident. So I'm constantly saying, okay, what can you see? What can you hear? What can you smell? I want to be able to kind of, if you're doing a good, what we call reliving, I should be able to have a full visual understanding of exactly what's happening, because you're wanting all of that information, somebody to talk through the incident. Then you record the incident, as you record them talking through the reliving, and the patient is asked to listen to it every night until the next session. And it's about just getting this narrative in their mind that it ends, you're okay, you survived, or whatever it is that the person needs to kind of update. You identify kind of hotspots within the memory, so points of intense emotion, and you can target them as well. Again, supporting the patient to develop adaptive information. How else could you have thought about it in that moment? What do you know now that you didn't know then? Again, as a way to kind of update the memory and move it into the hippocampus.
So to kind of like undo the triggers in a way?
Yes, yeah. So we could trigger desensitization. So wrestling between, the kind of the past and the present. What's happening now that reminds you that this is not happening again? Okay, well, I'm wearing a different top, or I'm driving a different car, or it's this day, or I can see this. Just kind of present moment stuff. And a key part of both of the interventions is reclaiming life, which is, the kind of the three key things that you're going to see is avoidance. So reclaiming life is about addressing that avoidance, doing the things again, that engaged you in life and helped you to feel a bit better. Hypervigilance, so constantly in your threat system, and hopefully the treatment is about bringing down that sense, that hypersensitivity. And then also the reliving, and that's what we do, the re-experiencing, and we do the reliving to target that.
We're nearing the end of our time together, Josie. So I just for the listener, just wanted to give you a heads up that whatever we talked about today is general advice, and it shouldn't replace what your doctor or GP, your psychiatrist can help you with. So if you feel you do need help, please contact those services. Also, today's topic was a bit difficult, and there's a lot more we could talk about. So we've given you kind of like a whistle-stop tour. There are other resources. Josie, do you have any books or resources if people want to find out more?
So The Body Keeps the Score by Bessel van der Kolk, Kolk, is a really good book, kind of explaining a lot about trauma. So I think that's one worth having a look at if you're wanting to know a bit more about trauma specifically. There's the EMDR Toolbox by Jim Knipe, which is Knipe. If you're interested in EMDR and wanting to know more about that, I think that's a good book to read. If you're interested in knowing a bit more about kind of complex emotional needs, quite an easily accessible and readable booklet that's been developed is Meeting the Challenge, Making the Difference. So you can access that. If you just Google that, I think you should be able to access that.
All hail Google. Okay, yeah. So Josie, thank you so much for your time today, and thank you for explaining these concepts so kindly. And I feel I learned a lot today. I hope it was enjoyable for you too.
Yes, absolutely. Thank you for having me. Yes, I hope it has been useful for other people.
And this is December, so Merry Christmas and Happy New Year, and we'll meet again next year.